going to try again, right? We've done this part. Let's see, y'all ready? Oh, crap.
Oh, there you go.
Yes.
There it is. Oh, yeah. Fixed it.
Yay.
Because I said a cuss word.
Now I'm about to tell you something else.
Just
You
cuss
got
it
us for
out.
recording. Are you recording?
Uh-huh. I think.
Okay.
Okay, let's see how we did. Somebody didn't vote, but that's all right. Oh. Because y'all already saw the answer.
That's
No?
what I guess the first time.
Okay, good work. Good job. All right, let's look quickly at the nervous system. Our nervous system is going to control all the things pretty much that happen in our brain, our thoughts, our sensations, our motor functions. This is important because when we're looking at head and spine trauma, this is where a lot of this problem occurs. Our central nervous system is made up of the brain and the spinal cord only. Central nervous system, the brain and the spinal cord. The peripheral nervous system is what? Everything else. How about that? Our vertebral nerves, cranial nerves, our motor and sensory nerves, all controlled by the peripheral nervous system. Y'all know this anyway, right? Because we did this in what, chapter 4, maybe? Briefly, the anatomy of the head. The cranium is where our little brain lives. We've got several facial bones. You need to be familiar with these. Not, early on when we looked at the skeleton, I'm not going to require you to know all of those facial bones. The mandible, where's the mandible? Y'all show me. Okay, the maxilla. What else we have up here? Nasal bones, everybody? Yeah. The zygomatic. Okay, pretty good. Those are the larger bones that you're going to encounter that break, that we see broken more commonly. The anatomy of the spine. We talked about this during our A&P chapter. It's important that you are familiar with these different categories. The cervical spine is C1 through C7. You can see here. The thoracic is going to be from a T1 to T12, so you've got 12 vertebrae. The lumbar, you've got 1 through 5. The sacrum and the sacroiliac, right down here, are all fused joints for a total of how many? 33, that's right. Which area is the most vulnerable? The cervical and the lumbar, because they're not attached. They don't have any supporting structures. Cervical 7, thoracic 12, lumbar 5, sacral 5 fused, coccyx 4 fused. Whoops. Man, that was way too fast. Forgot my own star. You need to know these divisions, and you need to know how many vertebrae in each one, okay? Ready with the star? Number of vertebrae in thoracic spine. Ooh,
That's not working.
it was working a minute ago.
It's not working.
So give me one of those nights, 3 chapters, and the stuff doesn't work for me. Who picked 7? Somebody. I know I'm going to have to write these down. Was it you? Okay. So we know somebody here is not being truthful. Okay, injuries to the skull and the brain. Here's where we're getting to the meat of it. Sorry, kind of breezed through that stuff. This would be, what type of wound would this be? Head wound, yeah. Open. Contusion. Abrasion. Laceration. Yeah, that would be a laceration. This looks like it's on the head, right? Would you expect this to bleed a lot or not so much? Yeah, probably so. They're just being kind here and not showing us all the blood. Do you think if an injury like this, looks like it's pretty much close to the top of the head, I think this is the ear over here, would you spinal mobilize this person? Probably so, yeah. With the scalp, anytime you get an injury to the scalp, you're going to get a lot of bleeding. It's very vascular in there, so they bleed a lot. Now, most of it's venous bleeding, so you may not get enough, they may not lose enough blood where you worry about shock so much, depending on how deep it is and how much bleeding you have. But generally speaking, it bleeds a lot. It looks like it's flowing a lot. You may get a little squirter in there, but they're usually small vessels, so you're probably not going to get, they're not going to bleed to death from this usually. Skull injuries, we've got got open head injuries and closed head injuries. Typically, we talk about an open wound as being what? Open to the outside, whereas a closed wound would be nothing open externally, right? When we talk about head injuries, we're talking about something a little bit different. I wonder if I got this on here. Let me check. Yeah, let me go back. When we talk about an open head injury, we're talking about is the cranium fractured, is the skull fractured. So with an open head injury, we're talking about is it broken completely? Is the skull broken and fractured? With a closed head injury, that vault is not fractured, and so the bone is not broken. Which one of those two do you think is going to be worse? The broken bone sounds worse. Yeah, when you think about it, if you've got it closed, you almost like have a compartment syndrome injury. Now, don't remember it that way. But when it's closed, there's no place for that swelling and that bleeding to go, except one place. Where is it going to go? It's not going out your eyeballs. It's not going out your ears. It's going to swell down to the brain stem. It's going to put pressure on your medulla oblongata. And that's where your respiratory center is. That's where your cranial nerves are. That's where you'll see the pupils of the eyes change. You know, you'll have a dilated pupil, or maybe even bilateral, depending on what's going on. But you'll usually see some respiratory involvement there. We call that brain herniation, when the brain material is being forced down through the foramen magnum, and it'll create that, to help to relieve some of that pressure in there. But you'll start seeing other signs of that brain injury because of that. So a closed head injury means that there's no break in the skull, and so all the pressure remains in. Whereas an open head injury does not necessarily mean that it's open to the outside. It means that the bone is fractured. Does that make sense? So don't be confused by that. A brain injury, we shorten that to TBI, traumatic brain injuries, as opposed to non-traumatic brain injuries. Can you think of a non-traumatic brain injury? That would be trauma, if you bumped your head. Yeah, I wasn't really thinking of encephalitis, but yeah, like a stroke, if they started bleeding in the brain, it would present just like you had a traumatic brain injury, but it wouldn't be due to a trauma. A concussion is one example of traumatic brain injury. Now, in your textbook, it lays out the different types of injuries and their severity and what types of signs and symptoms you may see with those. We're going to go over them briefly, but you need to review those because you're going to have patients that are going to present in each one of these different categories, and you need to be able to recognize that so that you know how bad it is. A concussion, when a patient has a concussion, the brain just kind of shakes around. There's not usually any real damage, and there's no permanent damage. Unless, you know, the studies are showing now that you get successive concussions, that it may accumulate, but typically a concussion doesn't have any detectable brain damage. Now, contusion, when you think about what a contusion is what? A bruise. So when you've got a bruise, then you've got some actual bleeding in there, right? That's what makes a bruise. So there are some ruptured blood vessels. Now, you'll be looking sometimes for evidence of a coup contra coup injury, which means that the brain has moved back and forth. More commonly, we see it from side to side, from ear to ear, not front to back. But those can happen, but most of the movement typically is going to be side to side. And bruising that occurs on the side where the blow had, usually, for instance, you see a patient that's hit from the side and their head goes sideways because the seatbelt doesn't really help you that much. And if you don't have an airbag over here, you may go to the side and you hit the window over here. Well, then you sling back. Well, the brain stops very quickly. It's a deceleration injury here, and then it slings back, and oftentimes it'll strike the other side of the skull, depending on how much space is in there. You know, if it's very tight in there, you may not get much movement. But say with an elderly person, you know, where the brain starts to shrink with age, then you may get more sloshing and more movement in there. So you may see evidence of a coup contra coup where they basically have bruising on both sides of the brain, which then when you've got more brain that's involved, more injured area, then you open yourself up to more bleeding, but you also may see different signs and symptoms based on where the injury has occurred. Talked about a laceration. We know what a laceration is if we see one on the outside, right? Well, the brain can be lacerated. Can you think of anything that can lacerate a brain? Yep, broken pieces or fragments of the skull. If the skull is broken, if we have an open head injury, we may have laceration to the brain. We may also develop a hematoma in the brain, which is where you have bleeding that forms in kind of pools, just like it does a hematoma in any other part of your body. So you've got a collection of blood within the tissue. So of all of these, which do you think is worse? I don't want any of them, but a hematoma, because it's going to be putting pressure on the brain as it continues to swell, as that pool of blood continues to grow. These hematomas can present in different places. Two that we see very commonly are subdural hematoma. If you break down subdural, where is this injury going to be? Where is this hematoma collecting? Below the dermal. We've got layers of the brain, so the dura is right up at the top, and so below the dura is going to be subdural hematoma. This is going to be the brain, between the brain and the dura. So let me get the next one. The epidural hematoma is going to be between the dura and the skull. Does that make sense? Let me see. Are the layers of the brain listed in there? What are they? The top layer is going to be the what? The bone. Yeah. What does arachnoid mean? I didn't spell it. Arachnoid. And then so if we've got the subdural hematomas between the brain and the dura, so it's going to be here, it's subdural, and then the epidural is going to be between the dura and the skull, so it's going to be here. So they're going to present differently. Y'all have all known somebody's gotten hit in the head at baseball, or fell off the swing and hit their head or something, right? Yeah, probably happened to half of you. I can kind of tell. Kind of get that glazed look when you've had a head injury. These thick eye. And then, of course, the intercerebral hematoma is where you actually have bleeding in the brain. I think I have it up here, the different presentations of these. Pretty sure I had that in here. That picture didn't come out very well at all. This is a picture of some increasing intracranial pressure. When they do a CT, they'll be able to see this area where the blood is accumulating. Based on some of the things I told you a few minutes ago, does this look like anything that you might suspect? Got bleeding on both sides of the brain? You might have a coup contra coup going on here, you think? Possibility. Okay, I got, I think I got some writing up here. Now, when you've got pressure on the brain from bleeding on the brain or the brain swelling, it's going to cause intracranial pressure. That's what ICP stands for. When you have a lot of pressure in the brain from the bleeding or the swelling, as the brain starts to herniate, remember what herniation is? What's that? Brain herniation. The brain actually does something. It becomes forced and squished down the foramen magnum. So it starts putting pressure on the brain stem. Once that starts happening, you're going to see other very obvious signs of a head injury. One is going to be, we'll see posturing. Posturing is a term that you'll see patients when they have a significant head trauma where they've got brain herniation, you're going to see posturing. And you know what posture is, right? You got good posture, bad posture. So we talk about posturing, then a patient that has a serious head injury will take on specific postures that you can recognize and identify them as being associated with a head injury. Decorticate posturing presents like this, where the arms actually draw up, kind of across the chest. Sometimes this, but mostly they're turned in and up. Whereas decerebrate is different. The arms kind of go out and turn. And the legs also do that too. Decorticate and decerebrate. I'll tell you how I remember those. I think of decorticate like somebody's tied them up with a cord. They're going to be uptight. Decerebrate sounds like celebrate, you know. So I know it's stupid, but it helps me remember. That's important. Brain herniation, that's when you're going to see decorticate and decerebrate posturing. Those indicate a very serious brain injury. Another thing you'll see commonly with increased intracranial pressure or a serious head injury is going to be projectile vomiting. And this is a special type of vomiting. This is not like my stomach feels really sick, I'm going to throw up all over you. This is the projectile vomiting where your patient is just laying there sedately, nothing going on, you know, you're trying to do all your stuff, and all of a sudden they just like vomit and it like hits the back of the ambulance and kind of rolls down. It moves past you at about 90 miles an hour. You hope it moves past you, not like onto you. But with projectile vomiting, because of its origination, it originates from pressure in the brainstem, the stomach doesn't get the message that it's nauseated. You know, you become nauseated for different reasons, but one, you've got something bad in there and your body wants to evacuate it. Or you've got really stressed and you're not digesting anymore and it just sits there and festers and then you kind of feel sick. With projectile vomiting, the patient doesn't feel sick. There's no impetus. There's no clue that they're going to vomit. You know, you can always tell when you're going to vomit, can't you? You go, this is not good. You're going to vomit. You hope your patient tells you in advance. Projectile vomiting, there's no sense that they're going to vomit. They just let it rip. And when they say projectile, it goes very forcefully up and out. So you do not want to be in the line of fire. So make sure that you're not like hovering over your patient with a bad head injury. Just kind of look what your line of sight is. Question? Forgot my own little thing here. All right, battle signs. Should have 3 more. Good work. Yeah. Where's the score? Y'all doing this? Oh my gosh. How many of you got it right? Huh, half of you? How many of you are telling the truth? Only a couple. Okay. Battle signs is going to be bruising behind the ears. How come we bruise behind the ears, you think, when you get a head injury? Yeah, gravity pulls it down, but this is only little space that's available back here. So it'll kind of pull back here because it's what we call a potential space. It can gather there. You're not going to see it if it's gathering up here, but it's gradually going to slide down. And so that's a gathering point. Okay, bleeds. Let's look at some of the symptoms. A bleed, we're talking about a bleed in the brain, okay? Symptoms. These are some of the things that I want you to be familiar with. An epidural bleed. Remember where the epidural bleed is? It's above the dura, so it's going to be up top here. An epidural bleed is an extreme emergency. Usually this patient is going to be symptomatic right away. One thing, probably 30% of the time they may present with a lucid period. This is the guy that gets hit in the side of the head with a baseball. You know, the batter hits it, the pitcher doesn't duck, hits him in the side of the head. In fact, was it Tampa Bay or somebody down there got hit with a baseball this week? No baseball fans in here?
Happened to my sister.
Happened to your sister. She played for
No.
the Devil Rays or
She
something.
went start change softball.
Did she get an epidural bleed from it? Or she just got hit in the head?
She got hit in the eyebrow. You could like see her skull.
Oh, she got a laceration there? Bleed? The whole bit, huh? Yep. With an epidural, usually they get hit with something fairly severe. We see it commonly with baseball injuries. But they may black out for, under a minute. They'll immediately lose consciousness, but they'll wake right up, and they're alert, and they're oriented, and everything seems fine. And they just look like, this is somebody we can send back in the game. It was temporary. They may not even lose consciousness. But within a very short amount of time, they lose consciousness, and unless they get care immediately, they die.
Is this what that woman had that died of the accident?
You know, except she didn't get in the hospital for several hours, I'm thinking. I'm just trying to remember. That was Natasha Richardson. Yeah. Now this is an arterial bleed, but it's high. But because it's arterial, they're going to lose a lot more blood. It is under a lot more pressure. It's still a small artery, but it's still arterial any way you look at it. But because of how high it is up here, it takes it a little bit, it'll take a few minutes before it gets down to really do that damage. So they have that lucid period. We see these with deceleration injuries sometimes. It may be of low velocity, but it's an extreme emergency. You know, with a head injury, particularly with kids, elderly people, they're going to the hospital. You'd rather be on the safe side than not. The subdural is a little bit different. I mentioned to you earlier that I had a patient one time that was a little boy that was swinging. He fell off the swing, and day by day he just got weaker and more, flaccid and more obtunded until they couldn't do anything for him. It was like 3 days before they got him to the hospital. So it's a slow bleed because it's a venous bleed, but it continues to bleed, and the patient kind of deteriorates slowly. It's not a quick thing like you usually see. You see it commonly in the elderly, and they'll have a slow bleed, and they'll have a gradual change in mental status. That's why it's so important, particularly with your elderly patients. You want to determine what their baseline is. How are they different today than, say, a week ago? Because there's so many medical reasons for a change like that, but it can also be a traumatic injury. And it may be such that they haven't really even bruised their heads. Because the brain is smaller, if they just got a sling like that, it could happen. But it's a slow bleed. You'll see an altered mental status. It's usually kind of gradual. This is the subdural. If they can get to it in time, then they can do something about it. It's the epidural that is the extreme emergency right now. Just because they appear lucid, they appear fine, they still need to be transported and rule out the possibility of epidural bleed. Okay? Y'all got those? Okay, think about it. These are some things that you want to consider when you're deciding how you're going to manage your patient. Does the patient have a serious or potentially serious head injury? What are you going to be looking for to determine that? The mechanism of injury, that's right. Should the patient be transported to a trauma center? This is something that as you get out there and you start practicing, you need to talk to other people that have been doing this for a while to find out at which point do you go to a trauma center. And it's going to vary based on where it is. I came out of Mobile. They had trauma centers everywhere. You can find a trauma center. Here, we don't have one locally. Our closest one's going to be Columbus or maybe even Atlanta, depending on where in the area you are. So you need to know where those places are and what the capabilities are of your local hospital so that you know what you're going to do. You also want to ask yourself if your patient's chief complaint or the mechanism of injury indicates spinal mobilization. If you just got a little cut to the head, maybe no big deal. So you're looking for specific energy transfer. If they have an altered mental status from a head injury, they're getting spinal mobilized. Because to me, that means there was enough energy transfer that they racked their brain a little bit. Is there a star there? Will y'all help me remember? I'm not even seeing them anymore. I need them to bounce around and have stars, flashing lights or something. And what type of bleed has a lucid period? Come on, y'all. 10. Got 14 in all. Come on, wake up, somebody. Who's sleeping? Okay, good. Okay, are y'all just like fooling with me here, picking the wrong answer? It's epidural. Whatever you have to do to remember that, just remember that, okay? Because you will see that again, I promise you. Okay, injuries to the head and face. What's the problem with injuries to the head and face? What's the big deal there? Bleeding, airway compromise, certainly. Cranial injuries with impaled objects. Didn't we see a picture of that already? Didn't I have an x-ray or something with an impaled object? We were talking about that in one of the other trauma chapters. If you got an impaled object in the head, and I've seen them and they're really freaky, it's amazing how somebody can drive a knife into somebody's head. Really? The nail gun part I get. I know how that gets in there, but how does a knife get in there? I don't know. But But you're going to stabilize it in place, just like we talked about. If you've got a knife sticking through somebody's skull into their brain, and every time that hilt moves, what's happening to the blade? Yeah, it's like a little pendulum thing. So make sure you stabilize it in place. What else do you have to worry about? What's the big S word you're probably going to be doing? If you've got, well, if you've got airway compromise. Suction, yeah. Injuries to the jaw and face, as we mentioned, airway is going to be your biggest problem. If you can position the patient so that they can drain themselves, that's always nice. If you don't suspect a spinal injury, what position you're going to put them in? You're going to put them in recovery position on their side, that's right. What about if you've had a spinal immobilize them, but they're losing so much stuff in their mouth, what can you do? If you just, if suction can't keep up, you can tilt the board a little bit, because you should have them fairly well immobilized on there. You can lift the side of the board so that can drain out the mouth, hopefully. We talked just a minute ago about non-traumatic brain injuries. We said those would be what? Easily, it can be a stroke. But a lot of the signs and symptoms are going to be the same. If you've got bleeding in the brain, whether it's non-traumatic or from a traumatic injury, you've still got bleeding in the brain. Now, you're not going to have an open skull fracture, an open head injury with a non-traumatic brain injury most of the time. But the signs and symptoms may be the same. So if you have a patient showing signs of a head injury, first thing you want to do is try to rule out a traumatic cause, right? There's no trauma involved, and you know it's not traumatic. And you'll suspect possibly a stroke. So mechanism of injury is what's going to lead you here. Now, there's something called the Glasgow Coma Scale, and it's something that you need to be fairly familiar with. Now, you're not going to have to figure this as closely as the upper level students, but there are questions about the Glasgow Coma Scale on National Registry. So my suggestion is that you become familiar with it. I think the biggest thing, if you can remember the number of points in each category, what the categories are, and then know what the points that are available for each one of those categories, you can pretty much figure it out yourself to know what the numbers are. Now, when we do our ABCs, our primary assessment, we're going to check their mental status, right? And we use the AVP. What does the A stand for? Alert. V is verbal. P, painful. And then U is unresponsive. Right, so that's just going to be very quick ruling in or ruling out, checking to see what their mental status is like. With the Glasgow Coma Scale, I think there are 15 points involved there, and your patient can be anywhere along that 15-point scale. Well, I take that back. They can't be below 3, which is pretty funny. Dead people get a 3. So why don't we just start at 0? Anyway, we use the Glasgow Coma Scale to help us determine if we should transport the patient to a trauma center, mainly. Now, the 3 parts of it are eye opening, verbal response, and motor response. Now, I put these in order of 4, 5, and 6. There are 4 parts of eye opening, 5 parts of verbal response, and 6 parts of motor response. If somebody has some acronym for EVM, let us know. Y'all work on that. What that may stand for to help you remember. Your textbook, what page is that on? Y'all got it?
759.
759? So I don't think I have one here. Yeah, eye opening, you want to know, it's kind of like the alert, verbal kind of thing. Or do they open their eyes without any stimulus at all? Do they only open their eyes when you call their name? Do they only open their eyes for a painful stimuli? Or are they completely unresponsive? So the eye opening is easy because that's AVPU, right? Beyond that, the verbal response, you're looking to see if they respond and you can understand them and they make sense. Now, it goes down from there, like, are they, what's the next one? It says you. Okay, so the second one is they're confused. So you ask them a question like, what were you doing when this happened? And they, say, well, I was at a birthday party. Really? You ran your truck into the tree? So they're confused. So they're going to give you different kinds of answers. The next one is inappropriate words, where you ask them a question and it's so off the wall, they're using words out of context. They're using the incorrect words as they're trying to talk. They can't differentiate the meaning of different words. And then the last one is, the second to last one is incomprehensible, is that what it says? Sounds, meaning they're not forming words. They're making sounds, they're grunting, they're garbled speech where it's not understandable. And the last one is there's no response. So that's going to be verbal. So if you kind of have a loose idea of what those are, you can figure out what the point should be. And then for the last one is a motor response. And here's where the posturing comes in. The first one is they obey your commands. If you tell them, to touch their nose and they come up to touch their nose, then they're going to get the full 6 points for that. If the second one is localizes pain. That means that if you pinch them, they can identify that and they can go there. Their brain can move them to that. They can localize where the pain area is. Withdrawals from pain. That means if you pinch them, they're moving away. They don't make any effort to, give you this number. They're withdrawing from pain. They can't recognize where it actually is. Flexion and extension. Flexion, is that going to be decorticate or decerebrate? Decorticate. This is going to be flexion, so that's going to be decorticate. So the next one is going to be extension. That's going to be decerebrate. And you'll see they lock their arms, they rotate them out, the legs, the feet kind of twist in like. And then the last one is there's no response. If you give them a painful response, they just lay there flaccid, totally unresponsive.
What about in cases like you see a lot in kickboxing where people get knocked out so hard that their body will fully extend? Is that like just a response to them being hit hard, or is that like a...
It wouldn't be this. It wouldn't be a brain injury that quickly because the swelling has to occur in order for that to respond. So it's probably more like seizure activity almost, where it just disrupts the electrical pathways and they seize like that.
Yeah.
But as soon as they hit the ground, they're out of it.
Yeah, it takes them a couple of seconds.
To kind of,
longer to
they've kind of been
wake up.
stunned like.
Yeah, they get up and they're just...
Yeah. That's funny how that works. But while you need to know these and be familiar with it, don't waste time on figuring this out. If you've got a patient with decorticate posturing, we're not going to hang around and go, let's see, she said, do this and then do that. It's none of that. Just move on with it. You recognize that it's bad. You can go back and figure out that if you need to. But you just need to be familiar with it because you may see it on National Registry. Do I think it's important that you know it? No, not really. But National Registry does, and you may see it. So I don't want you to miss this. So as you can see by the figures, that 1 is the lowest number you can get. There are 3 categories, so a dead person gets a 3. Figure that one out. Okay, wounds to the neck. I have a question for you here then, right? Saw the star myself. Dressing for a neck wound. What kind of dressing are you going to put on a neck wound? Two more. Come on, y'all. One more. Ah, good work. Okay. All right. Actually looking for occlusive here just because we're worried about the airway stuff. You don't want them to suck any air into a neck vessel. Pressure, the problem with putting a lot of pressure on there is it's hard to do without putting equal pressure here. So like you're not going to put a pressure bandage. You can put some pressure, but it's not going to be like you're trying to stop an arterial bleed or anything. But you will put an occlusive dressing on there. You may put a bulky and then an occlusive dressing on top of that, but you absolutely have to have an occlusive dressing on there. Okay, wounds to the neck. Large major vessels close to the surface create the potential for serious bleeding. We have some major vessels in the neck. Until you've seen one of those severed, you don't know the meaning of serious bleeding. Pressure in the large vein is lower than atmospheric pressure. So here we're talking about not artery, but a vein. And you slice that vein open, it's not under a lot of pressure, so it's very easy for it to suck air in. You do not want that to happen. Not good. We're worried about the possibility of an air embolus. Not good. Kills you. Best thing you can do for a wound to the neck is try to stop the bleeding and prevent them sucking any air in through their neck. It's kind of like we really shouldn't be sucking any air in anywhere except where? Right, through our mouth and nose, through our airway. So if we're sucking air in from the chest, what do we call that? Sucking chest wound. We're going to treat it the same way. You're going to put your gloved hand over it, get an inclusive dressing on it as quickly as possible. But of course, you're not going to build up any air in the neck, right, like you will in the chest.
What is air in
An air bubble that gets sucked in and travels through the vascular system. The question. We're going to talk about those again at the chapter 33, I think. Open neck wound, you want to make sure they've got a good airway. Place your gloved hand over the wound immediately. Apply an occlusive dressing. Apply some pressure to stop the bleeding. Occlusive dressing is going to go first here. A bandage. Because you may have other injuries around there. You may have the one where you've got that big wound, but you can have other injuries around there too. So you may end up bandaging. If you suspect that they've got a significant mechanism of injury, then you're going to want to take spinal precautions. All right. Okay, injuries to the spine. We've been working on long spine board, so this part should be kind of easy for you. Anytime you've got a serious mechanism of injury, anytime you've got some significant soft tissue damage or injury, really to pretty much from the chest up, you want to consider stabilization of the spine. You'd rather be on the safe side than not do it. Gee, we knew that. Spinal cords are relayed between most of the body and brain for sending messages. Very important. If that gets compromised, then if we have a serious spinal injury and the messages are not getting to the bottom part of the body, what type of shock are we looking at? I'm going for a different one. Starts with a D. This is a hint. Distributive. Distributive shock. If you think about that word, it's distribution. So what happens if you've got a break in the spinal cord right in the middle, then all the messages that go into the bottom part of the body don't get through. Remember when I told you if it's not getting any nervous stimulus down there, what happens to the vascular system? It becomes totally flaccid. It doesn't get the message to constrict. It doesn't even get the message to dilate. It goes beyond dilation. It just goes into total relaxation mode. So it's very difficult to maintain a blood pressure here because the blood just spreads out throughout the body. It's kind of like you tipped over that glass of milk, that milk just goes everywhere and you're just never going to get it back up. That's distributive shock. Neurogenic shock. I'm going to either post an audio or I'm going to write a little essay for you trying to explain these different kinds of shock. This is technically, neurogenic shock is technically a distributive shock. But you can also have neurogenic shock from a couple of other things too, which we'll talk about later. But uncontrolled dilation of blood vessels, if you put neurogenic shock, I'll take that. Just looking for distributive shock. There, right in there together. Okay, assessment of a spinal injury. Paralysis is going to be the #1 sign or symptom that you're going to be looking for. If they tell you, I can't move that, that's a pretty sure sign that they've got some type of a spinal injury. That could be temporary, but it could also be permanent. If it's painful, pain is going to be your second most common sign. If they're just sitting there and they say, my neck really hurts, that's a little bit different than, my neck hurts. Well, yeah, I guess because you're like moving it all around. So pain without movement is a serious indicator. Pain with movement often indicates a spinal injury. When you're palpating the spine, if they say it's tender, you want to consider a spinal injury. Impaired breathing, what's the cause of that? Here, with a spinal injury, you're worried that the diaphragm has been compromised. The nerves, it's innervating the diaphragm are compromised, so they may have problems with breathing. If there's any deformity to the spine, I mentioned priapism before, remember? That indicates a spinal injury. Loss of bowel or bladder control usually indicates a spinal injury. May indicate some other things, but it can indicate a spinal injury. So a lot of things that you'll be looking for, but could a person have a serious spinal injury and not have any of these? Yeah, they absolutely can. If they have a non-displaced fracture where everything is lined up and, you know, it looks okay, and then you start moving them and that motion injures the spinal cord, you've got to consider that. So even though they don't have any signs or symptoms, you're going to look at mechanism of injury and treat like they have it. You're going to provide manual inline stabilization. We've been all through this. You're going to assess their ABCs. You can usually kind of do this together. There's usually more than just one of you. So have somebody hold C-spine and then somebody else will start with the ABCs. And remember, you want to do a decent assessment of the head and neck before you put the collar on, because once you put that on, you're not going to have access to some of those spaces. So you want to palpate the back of the head real well, palpate the back of the neck, ask them if that hurts, is it tender, that sort of thing, before you put that on. And then you want to go ahead and assess their pulse, motor, and sensory fairly quickly. Mobilization issues. You know, when we practice this in class, I mean, we have all the space we need. But for some reason, when patients injure their spine, sometimes they're like trapped in cars and places we just can hardly get to. So you're going to have to be a real thinker sometimes. We talked about the seated patient. What's the device that we use for a seated patient? KED, Kendrick Extrication Device. We can also use, they call them vest type immobilization devices. And while the KED is the one that's almost universally used, you may see a short board. We used to call them pediatric boards, but they're short boards where it's almost like they've cut off a little bit less than half of the spinal board, and it usually is shaped more like the top of a person. So you may have those. You don't see them very frequently, but if your patient is stable enough, you need to use the KED. You know, you're not paid by the number of patients that you see. So take the time to do it right. If it were you or your family member who had the possibility of a spinal injury and they were stable and you pulled them out of the car on the long spine board rather than taking the time and using the KED and they end up with a permanent injury, how are you going to feel? Pretty bad. So take the time and do it if they're stable enough. If they're not stable enough, yeah, do the best you can to maintain that spinal integrity and pull them out. But I can tell you, if you're in the habit of always just pulling them straight out, whether they're stable or not, if you're pulling stable patients like that, sooner or later it's going to come back to bite you. All it takes is one in your career, and you go to court over it, and whether you win or lose, it doesn't matter if you've left somebody permanently disabled because you were just Johnny on the spot and you just pulled them right out. If you got the time and it's seen as safe and they're stable enough, put them in a KED. I've not ever had the problem, but I've had several friends that have had a good outcome because they took the time and put them in a KED. And, well, actually, I forgot. Yeah, I had a big guy. But anyway, yeah, we got him to the hospital, and he had fractured his cervical spine, but he wasn't showing any signs or symptoms. We put him in a KED. It was very difficult to attach. But anyway, take the time and do it. You'll log roll the patient. Try to pad the voids. How many of you guys have ever been on a long spine board for longer than 5 minutes? Nobody?
I don't know, it took like 30 minutes maybe.
I'll tell you what, they're very uncomfortable. If you're really skinny or even if you're large, you're going to have these voids and they're just not shaped like your back. You know, you don't have any support. They just lay you on them. And by the time you come off, you got more sores than, you know, somebody beat you up. So be very mindful of that. With my older patients, I like to, if nothing else, fold a sheet over 2 or 3 times and just lay it right on the board. If you've got one of those little thin blankets, I'll fold it over and just lay it flat on the board and then put the patient on there. But then once you're on there, you may have to slide some little towels or something up under their back, or sometimes under the upper back, depending on if they have a very large back. You might have to pad under the head to get a neutral alignment. So that's part of your job too. If they're pregnant, you don't want a pregnancy, a woman that's deep in her pregnancy to lay flat on her back. What happens there, you're like putting 25 or 30 extra pounds right on the pelvis, and you're putting pressure on the vena cava, and now they're not going to get any blood flow back from the lower part of the body, so they get dizzy, they pass out, their blood pressure drops. So you want to tilt the board just a little bit to the left. You can put just a little towel under the board, or you can like put a little towel or something under their hips. Either way, I like to do it under the board. But you don't have to tip them far, you know, just a couple of inches will do it. Just enough to shift that weight so it's not right on the vena cava. But remember, you're always going to secure the head last. When you're doing it, it's just like in the KED. We do the chest, the legs, and the head. Now, on your immobilization checkoff sheets, I don't think it tells you about your arms or anything like that. You don't really care. Whatever it is, it goes before you do the head. The head is absolutely last. You know why you do that? If you have to move them, but why not just do the head first?
Because
So they fall off.
Exactly. If you have a question?
Yeah, on the sheet it says torso, head, legs, arms in that order.
Yeah, don't do it that way.
Okay.
Those sheets, we spent about 4 years ago, they sent a contingent up to National Register to rewrite the sheets, and to my knowledge, they really haven't come out with anything. You understand why you do it in that order? If you've got this done and the feet done, somebody can hold the head. That just takes one person. You can tip that board up for them to vomit. But if you've got just their chest and you turn them up, their legs are going down, somebody can still hold the head, but imagine the top part of your body, now your legs are off like this. Is that going to hurt? Yeah, it could. So just do the chest, do the feet, do the head. As far as the arms, if they're unconscious, I always put them in. If they're alert and oriented, I don't have a problem leaving them out. So it doesn't really matter. I don't think the sheet really says specifically how to secure those. Anytime they're unconscious, you want them secured because they'll wave them out. The rapid takedown, we're going to do this in class, not in class, but in labs one day. Oftentimes you'll get on scene and the patient's out walking around and you start talking to them and they go, yeah, my feet are kind of tingling. You're going, oh, brother. But many times they're out walking around because, you know, number one, they think, if I get out of this car, it's going to be safer. And sometimes it is. If they're in the middle of the interstate, it may be safer to get out. And you'll see oftentimes where passersby will go ahead and pull a patient out because it's safer to be in the median than it is, you know, in the roadway. So you may have patients out walking around. You don't want to put the board on your stretcher and have them walk over and lay themselves down. You'll go to court over that. You want to bring the board up behind them. Somebody's going to hold the head. Somebody's going to see how they're holding under the arms. You got one under each arm, and you're going to lay the board down and hold them on it and then secure it. If they're sitting up against a tree, what can you do? KED, sure. And from time to time, you're going to have patients that are not going to be able to lay down. If they've got a pneumothorax, a hemopneumothorax, and as soon as you lay them down, what's going to happen? I ain't breathing anymore. So for those patients, you may need to do spinal mobilization. Put them in a KED, and then you sit them up as much as you need to so they can breathe. Because breathing is going to take priority. So sometimes you just have to problem solve. Okay, helmets. When to leave a helmet in place? Who can tell me this? Leave the helmet in place if what? If what?
I was saying if something like is impaled through it.
Well, probably definitely that's a good one. I had gone there before. If it fits well, if it's doing its job and it fits well, and you can manage the airway, you're going to leave well enough alone. If it allows the head to wiggle around in there, I mean it doesn't fit well, then it's not doing any good anyway, so you want to pull it off. If you suspect their airway is going to deteriorate, then you probably want to go ahead and take it off.
What about pressure?
Do what?
The brain pressure. Would that help?
I hope if they've got the helmet on, they won't have a brain injury. I can only hope. But that's the idea behind it. But yeah, if they start having respiratory distress because of brain herniation, then it's coming off. Yeah. If you're worried that if by removing it you're going to do further damage, that would be an impaled object. If you had to pull that out to get the helmet off, then leave it in place as long as you can manage the airway. Now, when you're spinal mobilizing somebody that's got this helmet in place, that changes the whole dynamic, doesn't it? They got a big old helmet. It's kind of like a football player with helmets and pads and stuff. Well, as long as the helmet and the pads are in place, you can easily spinal mobilize them. But if you pull the helmet off, and now they've got these big pads here, what's going to happen to the head? Well, yeah, so you're going to have to support the head. So if you keep the helmet in place, and there are no pads, now you have an issue too, right? You're going to have to pad under the shoulders to get a neutral alignment. So make sure that that's your goal, to get that neutral alignment, all right? When to remove the helmet? When to remove the helmet? Come on. When to remove the helmet?
Airway.
If they have respiratory distress or they got an airway compromise.
Doesn't sit right.
If it doesn't fit well, yeah. What else we got on here? Is there one more? If it interferes with your mobilization, you should be able to immobilize them with that in place. But if you just don't have the tools, you may have to pull it off. I think that's all. Y'all ready? Cardiac arrest, take the helmet off. Because it's going to be hard to manage the airway in cardiac arrest. Can you imagine trying to do chest compressions and their heads up like this because of the big helmet? All right, ready? What are raccoon eyes? Come on. Four more. Got some sleepers. Come on, come on, come on. Wake up. Come on, come on. Come on, come on. Going on without you. Aha! Aha! Oh, go back. It didn't come up. The right answer is bruising around the eyes. C, that's correct. This is another soft area through here. If you've got, you know when you get black eyes, same thing, blood just kind of pools down here. So like if you get the injury and then you lay on your side, what are you going to have? Black eye. Kind of just black eye. It's going to go to the dependent area. And you know what the dependent area is, right? The part on the low side. So like when we talk about dependent lividity, what's that?
Blood goes down the blood flow.
Where blood pools to the lowest point when somebody dies. So say you've got a patient that that you respond to and he's passed away and he's in a hospital bed. Where do you think his dependent lividity is going to be? Yeah, it's going to be in the sacral area because that's going to be the lowest point usually. Good job.
What part of the mortis stage is that?
I'm sorry?
Like there are different stages of mortis?
Yeah, you usually see that depending on if it's real cold or hot. Usually within usually about an hour you start seeing it, and then it progresses as it goes through. Do what? Yeah, and it will get in different stages, just like a bruise, really. And so when it's fresh, it's lighter color, more intense color, and then it moves into other colors. Okay, let's do a quick review. Two main portions of the nervous system. The central nervous system is made up of what? The brain, the spinal cord, and the peripheral nervous system is everything else. Good work. You will determine if you're going to spinal mobilize a patient based on what? Mechanism of injury. Pretty good so far. Spinal mobilization. Good. Altered mental status is an early and important indicator of a head injury. Now, if y'all go on in the program, head injuries get so very interesting because you can determine a lot about the injury itself based on what your patient remembers or their response. Altered mental status is a very early sign, and that's usually the first one that I look for, even before the pupils start going, anything else, because it seems like most of the time they start getting combative. In fact, just before I came up here, I read there was an article about two medics up in, I don't know, somewhere in the Northeast. Did y'all read it? that got attacked by a patient that had a head injury from a motor vehicle accident. And evidently, I mean, they had to restrain this guy. I mean, he beat him up pretty bad. They said he got a pair of scissors and started stabbing around and stuff like this. But this is very commonly the sign of a head injury. I mean, I've had numerous times where I've had to have the fire department guys that get in there and like sit on the patient, you know, until we could get them restrained because they're so combative. It's head injury all the way. They're not mad. They're not angry people. It's head injury. It's altered mental status from that. So sometimes it's just simple things like they've had a minor head injury and you ask them, well, because you want to determine if they're alert and oriented, right? Person, place, time, and event. Say, well, can you tell me what happened? And they go, no. And so they start asking you what happened. So you tell them, say, well, you drove your car off the road and hit a tree. Oh, okay. What happened? You know, it's kind of like, what was that movie? Every 10-second Dan? 51st Day? Yeah, the guy kept saying it. Well, he had the permanent. But you'll see this in your head injury patients sometimes. You'll tell them and then they'll forget. You know, after about the third time, you're going, if you ask me that again, you're going to have a permanent head injury. Or you're going to have a permanent wound to your chest because I'm going to stab you. It can be very annoying, but they'll do that and they can't remember. So based on the things they remember versus things they can't remember, it will indicate to you a lot about their head injury. So we go to that in the upper levels, but not right here. But you want to continuously monitor your patient's mental status to see if it's getting better or getting worse. You know, if it's just a concussion, you know, it may clear up before you get to the hospital. They may kind of get their senses going. But anything beyond that, particularly if it's a more serious concussion, you know, they could have some memory loss. So anyway, it's kind of interesting. Does your textbook talk about retrograde amnesia and that kind of stuff? And, no? You hate that stuff?
Oh, I remember that.
Okay.
I used to be so confused.
What else? Traumatic brain injury, disrupts the function of the brain. Anything from a slight concussion to a severe hematoma. What were the two types of hematomas that we talked about? Well, actually, we had three. Subdural, epidural, intercranial. Was it intercranial? Intercerebral, sorry. So which one of those has a lucid period? Epidural, you sure?
Yes.
Okay, good. Always secure the torso to the backboard before the head. What else? Closed head injury, the skull remains intact. Open head injury, the skull's been compromised. The problem with the closed head injury is there's no space for swelling in there. So where does that swelling go? It goes down to the brain stem, that's right. Neck wounds are at risk for air embolism. Compression, extension, y'all read about that. Rotation, the different types of spinal injuries. We talked about some of that before. Okay, does my patient have a mechanism of injury that indicate the need for spinal mobilization? Any traumatic injury, you always want to determine this. No matter what it was, I mean, they're going to do all sorts of crazy things to themselves. You want to look at the mechanism of injury and say, gosh, could they have injured their head or their spine? If yes, it's spinal mobilizing. Do they need to go to a trauma center? You need to consider that. Sometimes the patient's going to be so bad that your decision is made for you. But more times than not, they're going to be walking that kind of line. It's like, gosh, should I do it or shouldn't I? I usually err on the side of sending them if there's any question about it. But that's something you're going to determine within your department and your service. Okay. You're treating a patient with a head injury. He has an altered mental status and a significant mechanism of injury to the head. Your partner thinks you should hyperventilate. This is something you should have talked about in CPR. It's in your CPR textbook, so make sure you read this. When should you hyperventilate your patient? What are the signs and symptoms that would indicate this is necessary? Who read their book? Do you remember this?
Yeah, anytime you think they would help getting blood to the brain, or yeah, because you need oxygen to the brain.
While they do need oxygen to the brain,
Oh, and it helps reduce the brain swelling and keep the oxygen there so that it helps.
yeah, but it's not really, you don't want to vasodilate. And when you have a lot of oxygen in there, they tend to have more vasodilation, which you don't want unless the brain's herniated. Once, I have the answers in here. Once the brain is herniated, then you're going to hyperventilate. But hyperventilation is relative. The hyperventilation, we're talking about 20 per minute, not 30 or 40. Because, you know, if you're going 30 or 40, you're really not accomplishing anything. So 20, you know, 16 to 20 would be hyperventilation. Whereas normally, what's our ventilation rate for a patient, not in cardiac arrest, just respiratory arrest, say? Yeah, about, if they're breathing, you may be at 8 to 10. If they're not breathing, well, say, if they're pulseless, you're going to go less, like 5 to 6. If it's just respiratory distress, arrest, you'll go a little bit more. Hyperventilation is going to be about 16 to 20. We're only going to do that in the presence of brain herniation. And remember what brain herniation looks like? Brain herniation, you're going to have a severely altered mental status. You're usually going to have a pupil, a blown pupil, you know, where one is big and the other one's not. You may have unconsciousness. All those, you may have posturing, decorticate posturing, decerebrate posturing. Those are signs of brain herniation. So in the presence of those, then you're going to hyperventilate. Basically, it's just slightly hyperventilation. All right? That looks awful, doesn't it? Okay. Y'all take a quick break.